Good afternoon, Mr. Rafi. Please proceed to room 13, please. Again, Sir Rafi, to room 13. Thank you.
طيب تمام. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله الكريم. My name is Faisal Alhomayani. I'm a nephrology consultant in Taif University. That's my pleasure today to give me this opportunity to allow me to present arterial blood gases, this lecture, and I will thank all organizers who are responsible to prepare and organize this nice program in this difficult situation. And I believe this is this is the last lecture in this program, and I hope you will gain some benefit at the end of this lecture. So to save time, we will start. And maybe okay. And this is our objective. So first of all, I will define the arterial blood gases. Then I will try to help you to approach any arterial blood gas to interrupt and solve any data or any an investigation that you can face in coming new and near future. In addition to that, we will mention certain causes of abnormal arterial blood gases, and we'll solve together some cases as practicing. So initially, arterial blood gas, from its definition, it is analyzing of the gas that involve carbon dioxide and oxygen, and usually we are obtaining blood from the artery, so it is a painful procedure, and usually we are obtaining blood from either radial, brachial, or even femoral artery. So as we obtain it from artery, so it is one of the invasive and painful procedure, and need a little bit experience in staff who are obtaining this investigation. And we supposed to use all precaution method, especially in those patients who are using anticoagulation, because bleeding one of the common side effects. In arterial blood gas, typically we are assessing the acidity of blood by measuring the pH. pH, if it is in the lower, I have lecture now. Please, sorry. So I'm sorry because currently I'm in my clinic and I'm covering hemodialysis clinic. So in ABG we are getting information about acidity to the blood. So we are seeing the pH. So the pH, if it is going down, usually the patient has an acidosis. But if the pH is going up, likely represent an alkalosis. In addition to that, we are measuring the partial pressure of carbon dioxide, which reflect the amount of carbon dioxide gas that dissolved in blood. So indirectly, it will reflect the carbon dioxide exchange between the lungs and outside air. In addition to that, we are measuring the partial pressure of oxygen, which give us the same goal. In addition to that, we are measuring the main buffer in our system. That and the major contributor of the buffer in our system is bicarbonate. In addition to that, we are gaining information from oxygen saturation. ABG itself, it is one of the simple procedure. ABG itself, it can give us a clue about many information regarding the patient. So if you are analyzing or trying to interrupt the ABG, first of all, we suppose to get and not forget the clinical data that include history, taking, and appropriate physical examination. So if we are getting full information from history and physical examination, we can get more information of the ABG, which can help us and help all physicians to differentiate oxygen deficiency from primary ventilatory defect. And also, it can give us an information about different type of metabolic disorders. And usually the body will try to maintain the acidity of the blood within certain strict range to avoid complications that related to acidosis. For example, cardiovascular compromise and calcification, either vascular or extravascular. In addition to that, the body tries to help and maintain the acidity with normal range to avoid complication related to alkalosis that commonly related to arrhythmia secondary to electrolyte disturbance likely related to hypokalemia or hypocalcemia. So the acid to maintain normal acidity of the blood, the body have three main defense mechanisms. The first one is the chemical buffering. The chemical buffering likely represented from the action of the hemoglobin and the tissue buffer in extracellular fluid. For example, protein and bicarbonate buffer system within extra and intracellular fluid. So, for example, in case of acidosis, the generation of bicarbonate will be the concentration of bicarbonate will be very high. So the bicarbonate itself will bind and attack the extra hydrogen ions, which is the main contributor for acidosis. So binding of bicarbonate to hydrogen ions lead to formation of carbonic acid that can be dissolved easily and dissociate into water and carbon dioxide. And the extra carbon dioxide can be removed easily by lung, and some of them even can be removed by kidney. And if we are seeing this equation, which is one of the famous equation for acid-base balance, and that introduced by one of the famous scientists called Hansel equation. So according to the acidity, the equation or the carbonic acid can dissociate either to the left or to the right side. Another important organs that can work to restore and maintain acidity of the blood is the action of the lung. So in case of any acid-base disorders, respiratory or the lung will compensate and try to solve this issue very quickly due to have an ability to control the ventilatory drive via detection of pH changes in the brainstem. So in case of alkalosis, the respiratory system within brainstem will inhibit the ventilatory drive, and the vice versa in case of acidosis. And it is important to know that the lung or alveolar ventilation will work and compensate immediately within second and minute. And this we need this information if we are calculating the compensation in the coming slide. Another most important organs that can maintain and control acidity of the blood is the action of the kidney by controlling bicarbonate and hydrogen secretion, or bicarbonate reabsorption according to the status of the acid-base balance. But to compare kidneys from lung, the kidney usually require time. So the kidney detect the changes of the acidity of the blood, either in terms of alkalosis or in zone of acidosis by around 8 hours, and try to solve this issue started by 8 hours and complete compensation after around 1 day. So we cannot comment about compensation until patient finished 1 day duration or 24 hours. Yeah. This slide only to emphasize the importance of the ABG. ABG, as you know, the ABG, we are using mathematics. We are using standard number and equation. For that, the ABG, like, for example, an ECG, frequent practicing, especially the ABG, because there is fixed number and equation need to be put it in our mind, and because we are human beings, usually we are forgetting. So there are many literature done previously in the last few years to assess the knowledge of interrupt and solve ABG among different level of physician. So, for example, one of this literature was, I think, published in Australia. They prepare around 10 scenarios with ABG data, and they distribute each scenario to consultant, specialist, resident, and student. And surprising that student, they are solving ABG better than their colleague who are more experts. So the student, they solve it more than specialists, more than even consultant. So ABG, it is important to be reviewed frequently. Also, this example, it can give us a clue about the importance of ABG in diagnosis of some special cases. So you are called to see a 51-year-old man in the world who did a kidney transplantation 2 weeks ago. The kidney transplantation was done without any complication. But unfortunately, in the last week, the patient started to complain of shortness of breath. The transplantation was maintained on triple immunosuppressive therapy that include mycophenolate mofetil or MMF, in addition to tacrolimus, prednisolone, and Septra. Septra, this is a trimethoprim sulfamethoxazole that can be used for pneumocystis jirovecii infection, because there was outbreak of this infection in immunocompromised patient, especially in patients who received organ transplantation recently. On examination, the patient was desaturated. The saturation through pulse oximeter was 80%, and systemic examination was normal, including chest and cardiovascular examination. For that, the nephrologist and the physician who saw the patient, he did for him many blood tests, including chest imaging like chest X-ray and CT angiography. So the patient will prone to be harmed by contrast that used for angiography to rule out pulmonary embolism, especially for this kind of patient who get only one kidney. And unfortunately, there was no diagnosis of this condition. Fortunately, this patient has been seen by one of the brilliant physicians who asked to do an ABG. and the ABG has been done, and the pH was 7.44, and surprising, there was the saturation in ABG was 98%, and there was a wide discrepancy between the saturation on ABG compared with pulse oximeter. So in ABG, the saturation was normal, 98%, compared with the saturation on pulse oximeter. So the physician who ordered this investigation, at the end of the day, he was happy and happy because he approached and diagnosed this condition. Because this unique and pathognomic finding is unique for methemoglobinemia. Methemoglobinemia, it is either congenital or acquired condition resulting from altered state of hemoglobin in which the ferrous iron of heme are oxidized into ferric state. So unfortunately, the ferric have a difficulty to bind and even release oxygen to the tissue. So the oxygen will be stuck within hemoglobin and cannot be released easily to the tissue. So the oxygen dissociation curve will be left shifted, making the hemoglobin or red blood cells facing difficulty to release this oxygen to the tissue. So when we are assessing the ABG, the red blood cells are rich in oxygen. However, the tissue will pour on oxygen that represented by poor oxygen on the pulse oximeter. And as I informed you, this is either congenital or acquired condition. And acquired condition likely is secondary to drugs. One of those drugs that can cause methemoglobinemia is sulfa-containing drugs, like, for example, the Ceftra, which the patient are using. In addition to that, another common drugs like nitroglycerin or any other nitrate, lidocaine, metoclopramide, and the presentation of methemoglobinemia, it depends on the concentration of the methemoglobin within blood, and usually the symptoms related to disturbance of the cardiovascular or respiratory symptoms, and patient can present it with central cyanosis. And as we know, if we consider any diagnosis, we suppose to confirm this diagnosis and confirmation of the methemoglobinemia by measuring the methemoglobin concentration by using the wavelength co-oximeter. So we got from this scenario the importance of ABG. So through ABG, we can diagnose even simple condition. We can save time and waste and avoid wasting even money and avoid harm patient to use any other invasive procedure. Okay, we will, through the coming slide, we will give you clue or steps to solve any ABG that you can face it in coming few days. And before as I mentioned, in ABG we are getting information, and the data will represent the pH, BCO2 bicarb, and BO2 and saturation. And I want from you to know the normal adult arterial value. So the pH, the normal level is between 7.35 to 7.45. And I want from you to remember the red color numbers, because we'll use these numbers to solve the ABG in the coming slides. The standard number for BCO2 will be 40, and the standard number for bicarbonate is 24. In addition to that, we're supposed to know even the normal adult venous value if we are using ABG instead of ABG, if we are using the venous sample rather than arterial sample. And usually the venous sample is more acid and the pH is different by around 0.05 compared with the arterial pH, and the BCO2 is raised by around 5 compared with the arterial blood sample, and the bicarbonate seems to be the same. And I want from you even to remember the red numbers. Right. While I mentioned to you the standard number for PBG, so I will ask you, could we use PBG instead of ABG? Because I informed you previously that the ABG, it is one of the invasive and painful procedure, but especially if we are, especially in any condition, usually we are requiring to do ABG frequently. For example, at least 4 to 3 times per day, especially in patients who are admitted on the intensive care unit. But the ABG seems to be more easy. So we're supposed to answer these questions. So, to save time, I will answer these questions. Unfortunately, we couldn't use PBG in case of respiratory disorders because of the concentration of both oxygen and carbon dioxide is widely different from patient to patient, and even the concentration of oxygen and carbon dioxide is not stabilized, and usually it's different from time to time and cannot be corrected. But if patients have, for example, pure metabolic disorders, like for example, pure metabolic acidosis or pure metabolic alkalosis, we can use the ABG. So first of all, we're supposed to rule out presence or absence, presence of respiratory disorders, and if we confirm that patient have a metabolic disorders, we can use ABG to make this test more efficient for patients. As you know, we have 2 main acid-base disorders, either respiratory or metabolic. And each one of them are divided into 2 types, either acidosis or alkalosis. So we have 4 different types of acid-base disorder or disturbance. One of them is the first one, which I mentioned in this table, is the respiratory acidosis. So the primary disturbance is rising of the BCO2 because the carbon dioxide, it is, as you know, it is acid. So the primary disturbance, there was a retention or high concentration of the acid. That in this disorder is the CO2. So the BCO2 will be very high. So in response to this, the pH will go to the acidic zone. So the pH will be low. So the BCO2 will be high. So in response to that, the pH will be low. So to correct respiratory acidosis, the kidney will try to solve this issue by resorption, more alkali. So the body will, so the respiratory acidosis will be compensated by metabolic alkalosis. So the concentration of the bicarb will be very high. Right. In case of respiratory alkalosis, so because the patient have a respiratory alkalosis, the primary disturbance of this disorder is dropping of the BCO2. So if there is dropping of the BCO2 or the acid, the pH will go to the alkaline phase. So, and respiratory alkalosis will be corrected or compensated by metabolic acidosis. So there was a reduction of the concentration of the bicarbonate. The third one is metabolic acidosis. So the primary disturbance of the metabolic acidosis is dropping of the concentration of the bicarbonate. And because of the dropping of the alkali of bicarbonate, the pH will go to the lower side, will go to the acidic side. And to correct metabolic acidosis, the lung will activate hyperventilation to remove or wash out the extra carbon dioxide. So the concentration of the BCO2 will be very low. And the reverse will occur in metabolic alkalosis. So in metabolic alkalosis, the primary disturbance is rising of the concentration of the alkaline in the blood, which is the bicarbonate. And in response to that, the pH will go into higher side if it is not compensated. And in response to that, the metabolic acidosis will be compensated by respiratory acidosis. So the ventilation will be inhibited or suppressed. So the ventilation, so the concentration of carbon dioxide will be high. Compensation. In any ABG, we're supposed to calculate the compensation, because if patient affected by any metabolic disturbance, by any metabolic or respiratory disturbance, the other organs which are not affected will try to adapt the situation and try to solve and maintain acidity within normal range. So for example, in case of metabolic acidosis, usually the body or the lung will try to correct this acidosis by respiratory alkalosis. However, the respiratory alkalosis should be determined to see if this respiratory alkalosis either adequate for the degree of metabolic acidosis or not. How to assess this adequacy? By comparing the measured, for example, BCO2 to the expected BCO2, and all measured or expected BCO2 all supposed to be the same. So, however, if there is a difference, it's likely another process exists. So if the BCO2 or the concentration of BCO2 in case of metabolic acidosis are dropping, but dropping or falling, but not to the expected level, usually the patient have another disorders or respiratory acidosis in addition to metabolic acidosis. But if the BCO2 is dropping more than expected, usually the patient have another process or respiratory alkalosis in addition to metabolic acidosis. And I will give you many ways to assess this compensation. So in case of metabolic acidosis, we can use the Winter formula to assess the expected BCO2. So the BCO2 is supposed to be equal to 1.5 multiplied by bicarbonate plus 8 plus 1 plus or minus 2. But as I mentioned before, if the failure of BCO2 to decrease to expected value, so likely patient have, in addition to metabolic acidosis, will have another acidosis that called respiratory acidosis. But if the expected BCO2 fall beyond the expectation, the patient will have another process or respiratory alkalosis in addition to metabolic acidosis. Another ways to assess the expected BCO2 by checking the last 2 digits of pH that usually approximate the BCO2. In case of metabolic acidosis, we can compare a change of bicarbonate to the change of the BCO2. For any increase of the bicarbonate by 1 milliequivalent per liter, for any increase of of bicarbonate by 1 milliequivalent per liter, usually the BCO2 will raise by around 0.7. Right. In case of respiratory acidosis, usually will have 2 different scenarios. Either patient have acute or chronic respiratory acidosis. So in case of acute respiratory acidosis, for any rising of the BCO2 by 10 millimeter mercury, usually the bicarbonate will raise by around 1. And in case of chronic respiratory acidosis, for any raise of the BCO2 by 10, usually the bicarbonate will raise by 3.5. So it is important for us to differentiate between acute or chronic disorders because there is wide difference in numbers. So to say this patient have acute respiratory acidosis, it depends on 2 things. So if patient, for example, have chronic lung disease, for example, chronic obstructive lung disease, or for example, chronic asthma, we will assume this patient to have, for example, chronic respiratory illness. So if patient known to have chronic lung disease, we will use the second formula. Tamam? But if patient did not have chronic lung disease, we will use the first formula. Another way to differentiate acute from chronic respiratory illness by checking the onset of symptoms. So if the onset of symptoms is beyond 8 hours, we will assume this patient to have chronic respiratory illness. But if the onset of symptoms is within 8 hours, we will assume that patient will have acute respiratory illness. And in case of respiratory acidosis, usually will compensated by metabolic alkalosis. So in case of metabolic alkalosis, usually it will be characterized by raising of the bicarbonate, and the rising of carbonate will supposed to be within expected range. But if you are facing of the failure of bicarbonate to increase to expected value, usually this patient have, in addition to respiratory alkalosis, have an extra metabolic acidosis. But if there is excessive increase of the bicarbonate that beyond the expected value, usually the patient have metabolic alkalosis in addition to respiratory acidosis. Right. The fourth one is the fourth acid-base disturbance is respiratory alkalosis. So also divided into acute and chronic illness. So can be differentiated by presence or absence of chronic lung disease, and can be differentiated by the onset of symptoms. So if patient known to have chronic lung disease, we'll consider this patient to have chronic respiratory illness. And if the illness or if the symptoms is beyond 8 hours, we will assume this patient to have chronic respiratory illness. But if it is not beyond 8 hours and patient not known to have chronic lung disease, we will consider this patient to have acute respiratory illness. So, and in case of respiratory alkalosis, the compensation for each drop of the BCO2 by 10 milliequivalent per liter, usually the bicarb will drop by 2. And in case of chronic respiratory alkalosis, for each drop of BCO2 by 10 millimeter mercury, the drop bicarb is range from 4 to 5. And if there is a failure of bicarb to decrease to expected value, usually another metabolic illness present that present metabolic alkalosis. And if there is excessive decrease of bicarb in it, so the patient will have metabolic acidosis in addition to respiratory alkalosis. This is the third way, and this ways which I used to solve and interrupt any ABG and to calculate the compensation in any acid-base disturbance. So I want from you to understand these equations, and in addition to that, to remember the numbers which that are colored by red. So in case of metabolic acidosis, so remember 1.2, and in case of metabolic alkalosis, remember 0.6, and in case of acute respiratory acidosis, remember 0.1, and in case of chronic respiratory acidosis, remember 0.3, and in case of acute respiratory alkalosis, remember 0.2, and remember 0.4 in case of chronic respiratory alkalosis. Because I will try to explain this equation. These red colored numbers are represent the change of either bicarbonate or BCO2 in relation to another. So changes of bicarbonate in relation to changes of BCO2 or vice versa. خلاص؟ تمام. So in case of metabolic alkalosis, we suppose to assess the compensation that's supposed to be by respiratory alkalosis. So for that, we supposed to calculate the expected BCO2. So in case of metabolic acidosis, we knew that we will use this standard number, which is 1.2. And because the patient have a metabolic acidosis, I suppose to multiply it by the primary disturbance. The primary disturbance هو metabolic acidosis. So I will multiply it by corrected bicarb, which represent the primary disturbance. The corrected bicarb is equal to الميجرد that الميجرد اللي ناخذها من ABG from an investigation. Then I will minus it from 24. طيب, so in case of metabolic acidosis, I will use the standard number 1.2. Then I will multiply it by primary disturbance. The primary disturbance اللي هو metabolic acidosis. So it changes في البايكارب. It changes في البايكارب. So I will multiply it by something called corrected bicarb. الcorrected bicarb في أول سلايدات قلنا إنه standard bicarb اللي هو 24. So I will minus or distract 24 from the measured bicarb. The measured bicarb, we will get it from the lab investigation. تمام? Then, in case of metabolic acidosis, usually will be compensated by respiratory alkalosis. So, in case of respiratory alkalosis, the concentration of carbon dioxide will drop. So I will use minus, not plus. So because of the concentration of the BCO2 will drop, because in case of metabolic acidosis, it will be compensated by respiratory alkalosis. And in case of respiratory alkalosis, the patient will be hyperventilated. So the concentration of the BCO2 will be dropped. For that, I will minus it. I will use minus from standard concentration of BCO2 اللي هي 40. Then plus minus 2. This will give us a range of expected BCO2 in case of metabolic acidosis. طيب. I will explain the other process. In case of metabolic alkalosis, I will use this standard number. That is 0.6. And in case of metabolic alkalosis, I will multiply it by the primary disturbance of these disorders. The primary disturbance of disorders اللي هو change في concentration of bicarbonate. So I will multiply it by the corrected bicarb. The corrected bicarb اللي هو measured اللي هو which we get it from the lab or from the actual ABG for the patient. I will minus it or distract it from the 24 اللي هو standard bicarb. And in case of metabolic alkalosis, it will be compensated by respiratory acidosis. So in case of respiratory acidosis, the ventilation will be inhibited or suppressed. So the concentration of the BCO2 will increase. So I will add, not use minus. So I will use plus, not minus. So I'll use plus 40 اللي هو standard number of BCO2, then plus minus 2. So this range, it will give me the expected BCO2. طيب آخر واحد لأنها كلها تقريبا زي بعض اللي هو in case of respiratory acidosis. In case of respiratory acidosis, if it is acute means that patient does not have chronic lung disease and the symptoms is less than 8 hours. So in case of acute respiratory acidosis, I will assess the adaptation or compensation by metabolic alkalosis. So I will calculate the expected bicarb. So I'll use the standard number. Standard number is 0.1. Then I will multiply it by primary disturbance in this acid-base disorders. Acid-base disorder in this scenario, in case of respiratory acidosis, primary disturbance with the concentration of bicarbonate, with the concentration of the BCO2. And so I will multiply it by corrected BCO2. Corrected BCO2 اللي هو actual BCO2 minus standard BCO2 اللي هو 40. Then, in case of respiratory acidosis, usually will be compensated by metabolic alkalosis. So, in case of metabolic alkalosis, the kidney try to reabsorb most of the bicarbonate from the proximal tubule and try to remove all extra acid from the distal and collecting tubule. So we will try to save bicarbonate. So because we will try to raise the alkali. So I will add, not minus. I will add a standard number bicarbonate plus minus 2. And we can use the same theory in the other acid-base disturbance. Could you please give me 5 minutes because I have an urgent issue and I want to solve it. So only 5 minutes, then we'll resume our presentation. for this interruption because I have some simple issue which already solved. Fine. So now we'll start to we'll start our practical zone. So we'll start with, and I will mention certain steps that we supposed to use it in any ABG that you will face it in any time. So first of all, if you are seeing an ABG, the first step to assess LBH. So and we have the standard number, which is 7.4. So if the BH is less than 7.4, usually the patient are turned in the zone of acidosis or acidemia. But if the BH is more than 7.4, likely the patient in zone of alkalosis or alkalemia. But if the patient have normal BH 7.4, it's either the patient have a mixed acid-base disturbance, because as we mentioned previously, we have a compensation process, or patient may have normal ABG. The second step, we supposed to check the concentration of the carbon dioxide or PCO2. Why we are not using bicarbonate? Because usually the lungs will adapt and compensate immediately within seconds to correct acidosis, not like the kidney, because the kidney, as we mentioned, it requires time. So it starts to compensate by 8 to 12 hours and complete compensation by around 1 day. So the PCO2, it is more accurately represent an acid-base balance or disorders. So in case of low pH or acidosis, if patient have high concentration of PCO2 اللي هو استخدمنا standard number more than 40, likely the patient have a respiratory acidosis. But if patient have acidosis but the PCO2 is less than 40, likely the patient have a metabolic acidosis. But in case of alkalosis or high pH, if the PCO2 is high, likely the patient have a metabolic alkalosis. But in case of alkalosis, but the concentration of PCO2 is low, less than 40, likely the patient have respiratory alkalosis. طيب. طيب, I will skip this slide. طيب. Another important slide and another important step that I want from you to remember it. If you are seeing any ABG, it is important to calculate the anion gap. In any ABG interpretation, one of the mandatory steps to assess an anion gap because of the high anion gap metabolic acidosis can be associated and can be coexist with any acid-base disorders. So one of the mandatory steps, if you are analyzing or interrupt ABG, to calculate an anion gap. Usually there is no difference between anions and cations in the body in extracellular fluid. So usually the patient or human have neutral charges. So no difference from positive charges or cations compared with anions. However, not all labs are able to measure all cations or anions in the body. For that, we are using the major contributor anions and the major contributor cations. The major contributor cations include sodium, and the major contributor anions is represented by chloride and bicarbonate. And while we are not using potassium because it's running low concentration within extracellular fluid, usually reference range or reference anion gap is around 12 plus minus 2. So it's from 10 to 14. طيب. And if you are calculating an anion gap, it is important for us to not miss the main causes that can be associated with low anion gap. Like, for example, hypoalbuminemia. So in case of hypoalbuminemia, the anion gap need to be corrected. So the calculated anion gap will be, we'll use this equation. So the calculated will be plus 4 اللي هو represent the standard number of albumin gram per deciliter minus the actual albumin, for example 3. So 4 minus 3 will be 1, then multiplied by 2.5. Like another method that can be used, for any drop of albumin by 1 gram per deciliter, you should, for any drop of albumin by 1 gram per deciliter, you should drop or fall calculated anion gap by 2.5. So if anion gap if the albumin, for example, if the albumin is, for example, 3, tamam, so a drop around 1 gram per deciliter. And if you are calculating an anion gap and it was, for example, 10, you should correct this anion gap by subtract 2.5. فيصير the corrected anion gap around 17.5. But in case of albumin, we have this fixed equation. But unfortunately, if there is a rising, if there is a huge concentration of the cations, for example, cationic light chain in case of multiple myeloma, unfortunately, we couldn't have a formula to correct an anion gap. For that, we can misdiagnose patient, and we can diagnose patient wrong way. So so how do you think that we can diagnose these type of patient? So if in case if you are facing a patient with multiple myeloma, so unfortunately we didn't have any equation. For that, we suppose to review a previous baseline anion gap. So if the previous calculated anion gap, for example, was 10, but unfortunately after 1 month the patient was deteriorating and patient now in blast crisis, and the calculated one is the same, 10. So I will assume this patient to have high anion gap. Another method to avoid ignoring this condition by asking certain facility to assess the electrodes or charges within patient lab. But unfortunately, this type of investigation, it will be not available in our facility. Another step, or the fourth step, if you are analyzing any ABG, to assess the condensation by using the previous formula. طيب نبدأ بأول سيناريو. أول سيناريو, you are called to see 54-year-old lady on the ward. She did or underwent post-cholecystectomy 3 days, and since then the patient complaining of shortness of breath. So the patient have a shortness of breath that has been started in the last 3 days, and from this scenario the patient likely have a respiratory issue because of the respiratory symptoms, or patient may have so the patient likely may have a respiratory illness, and this respiratory illness I will assume or I will consider it as chronic because it's beyond 3 days, or may the patient have metabolic acidosis, and in case of metabolic acidosis, the body will compensate that by inducing or promoting hyperventilation. So may the patient will have a cosmal breathing or rapid breathing, and may have a shortness of breath. So it is important to add history and physical examination to our ABG. And his ABG data is the following. The pH is 7.49 and BO2 around 90, BCO2 29, and bicarb is 21. And the other values within normal range. So we will follow and use the hour that previously mentioned steps. So the first step, by checking LBH, and we have standard number, 7.4, and I will compare 7.4 to the patient or actual pH, and the actual pH is 7.49, so it is more than a standard number, 7.4. So the patient likely in alkalosis or patient have alkalemia, and the second step to check LBCO2. الBCO2 we have standard number اللي هو 40, and the actual number or actual patient number is 29, and 29 is less than 40, so the patient likely have respiratory alkalosis. A third step to assess compensation. So in case of respiratory alkalosis, we suppose to assess a compensation. Well, compensation is supposed to be by metabolic acidosis. So I will use 0.4 because the patient have chronic illness, and the primary disturbance in the patient scenario is respiratory. So I will multiply 0.4 اللي هو standard number by corrected primary disturbance اللي هو respiratory alkalosis. So I will multiply it by corrected BCO2. وقلنا المريض عنده respiratory alkalosis. So it will be compensated by metabolic acidosis. And in case of metabolic acidosis, we are usually the kidney will try to remove or remove the extra acid and decrease reabsorption of bicarbonate. So I will minus it or subtract it from standard bicarbonate plus -2. And finally, I get 19.2 plus -2. So then I will compare this expected bicarbonate to the patient or actual bicarbonate in a 17.6. Range is 17.6 to 21.6. I will compare it by 22. Like any numbers that beyond 0.5, I suppose to correct it. أو نجبرها جبر. فالمفروض يكون from 18 to 21, and the actual is 22. So I will compare. So it is within the patient range. So the patient have respiratory alkalosis that has been compensated by metabolic alkalosis. But if the expected BCO2, for example, is 16, so it is dropped, for example, it's 16 or 15, so it's dropped beyond this range, likely the patient will have respiratory acidosis and another acid-base disorders اللي هو metabolic acidosis. لكن if the number by bicarb, for example, is 25, so the patient will have a respiratory acidosis. In addition to that, the patient will have metabolic alkalosis. So the patient will have double acid-base disorders. The primary and the most common acid-base disturbance that usually faced in emergency or even ICU is the metabolic acidosis, which characterized by disturbance or drop of the bicarbonate level, leading to low pH and respiratory compensation, resulting in low BCO2. Metabolic. If you are facing any patient with a metabolic acidosis, it is important for us to add additional order and differentiate the two famous type of metabolic acidosis. And the metabolic acidosis will be classified into either high anion gap metabolic acidosis or HAJMA, and normal anion gap metabolic acidosis or NAJMA. So these can be differentiated by measuring anion gap. So if the anion gap will be high, so I will consider HAJMA. And if the anion gap will be within normal range, I will consider NAJMA. And this method, it will help me to narrow our differential diagnosis, because each one of them have a list of differential diagnosis that we will mention it in the coming slide. And if patient have high anion gap metabolic alkalosis, also it will be unfortunately subdivided into two categories or two groups, either high or normal osmolar gap metabolic acidosis. Sorry, what? This patient need to be referred to. Excuse me, 1 minute. You have 4 Egyptian physicians, and all of them, their weight is more than 90, and they're supposed to work. And one of them, we will consider it as a lead physician.
They are telling, ask you.
Say Faisal now is busy, and they aware that I'm busy. Right. Sorry for this interpretation. As I mentioned, the high anion gap metabolic acidosis is subdivided into a high or normal osmolar gap, and we will mention to narrow our differential diagnosis, and also it will help us to treat those type of condition. The osmolarity, to calculate the osmolarity, we're supposed to measure all osmotic active substance with the body, and the major contributor for the osmotic active substance will include sodium, glucose, blood, urea, nitrogen, and the other osmotic active substance that usually running within circulation is running with low concentration and usually below 10. So usually we are ignoring these substances. And why we are divide glucose, for example, by 18 and blood urea nitrogen by 2.5 to unify our unit to make all of them in millimole per liter. So if you are seeing seeing an investigation, for example, glucose in milligram per deciliter, you should convert it to millimole by divided by 18, and in case of blood urea nitrogen, if you are seeing a patient with milligram per deciliter, you should divide it to millimole per liter by divide them by 2.8. But for example, in Armed Forces Hospital, they are using unified forms, so they are using the millimole per liter. So no need to do this division. We'll go to the second scenario. So we are seeing a patient who is a 32-year-old man present to emergency department, and unfortunately he was found by his mother collapsed at his home, and on emergency department the patient was serious. The pH was 7.35, partial pressure of oxygen is 91, partial pressure of carbon dioxide is 20, bicarbonate 11, potassium 4.5, sodium 135, chloride 100, and other lab was within normal range. These are the ABG data. So we'll go step by step, and we'll use the same algorithm that have been used in the previous scenario. So first of all, I will use the pH. the pH of the patient is less than 7.4. So the patient have an acidosis. Then second step, I will use the PCO2. And we have standard number اللي هو 40. And the PCO2, the actual PCO2 is less than 40. The actual PCO2 is 20, or 20 less than 40. So the patient simply have metabolic acidosis. For that, it is mandatory to calculate the anion gap to narrow our differential diagnosis. Anion gap, I will use sodium chloride and bicarbonate. So the sodium 135 minus 100 plus 100, that equal to 24. And 24 is more than 14. And our reference range of normal anion gap is from 10 to 14. So the patient have simply high anion gap metabolic acidosis. The fourth step, to assess the compensation. So in case of metabolic acidosis, usually will be compensated by respiratory alkalosis. So I will calculate the expected PCO2. The expected PCO2 in case of metabolic acidosis, I will use the standard number 1.2. Then I will multiply it by the primary disturbance in patient scenario. In patient scenario, the primary disturbance was metabolic. So I will multiply 1.2, which is standard number, by corrected bicarb, اللي هو actual bicarb minus 24. And because the metabolic acidosis will be compensated by respiratory alkalosis, and in case of respiratory alkalosis, there will be hyperventilation. So there will be washout or dropping of the PCO2. So I will minus it from the standard PCO2 اللي هو 40. Then I will calculate a range. So 24 minus 11, range can 22.4 to 26.4. So I will compare an expected PCO2 with the patient or actual PCO2. An actual PCO2 was 20. So the PCO2 is dropped more than expected. So the actual PCO2 is dropped more than expected. So this patient have another respiratory illness اللي هو, so the patient have high anion gap metabolic acidosis associated with other respiratory illness اللي هي respiratory alkalosis. لكن if the PCO2 or the actual PCO2 within this range, I can say the patient will have high anion gap metabolic acidosis compensated by respiratory alkalosis. But if the PCO2, for example, is 30, I can say the patient have high anion gap metabolic acidosis with respiratory acidosis. Right. Because the patient have high anion gap metabolic acidosis, I informed you to add an extra step. An extra step is to calculate an osmolarity, because the normal osmotic active substance that normally run in our circulation is less than 10. If more than 10, make sure that patients are taking toxins or any toxins or other material which has ability to raise the osmolarity, like for example toxins, or for example contrast media, or certain medication like mannitol. So it is important to calculate an osmolarity. So we will use this equation. So we are using a major contributor, or a major osmotic active substance contributor that represents sodium, glucose, blood, urine, nitrogen. Then I will subtract this number from measured osmolarity. إيش هو measured osmolarity? اللاب, it will measure all osmotic active substance, including sodium and glucose, blood, urine, nitrogen, in addition to any substance that are active. And usually a normal usually less than 10. If more than 10, make sure that patient have or ingest a toxins. طيب طلع هنا calculated around 28 والmeasured اللي هو 2087. So the osmolar gap is less than 10. So the patient have normal osmolar gap. But if the osmolar gap more than 10, make sure that this patient are taking a toxins or any other material from outside his body. But within 10 or less than 10, likely this represents another negligible osmotic active substance that normally circulating in our plasma. طيب هنا تعلمنا انه في الهاي انيون جاب تعلمنا سوري في اي ABG interpretation to measure anion gap in any scenario. طيب in case of high anion gap metabolic acidosis تعلمنا to add two extra steps. In addition to calculating an anion gap, it is important to measure an osmolar gap to differentiate high from normal osmolar gap, high anion gap metabolic acidosis. In addition to that, in case only of high anion gap metabolic acidosis or HAJMA, we suppose to check a delta ratio or gap ratio to assess ratio changes of bicarbonate to the ratio of changes of corrected anion gap. والgap ratio will use this equation اللي هو corrected or delta anion gap ratio divided to the corrected or delta bicarbonate ratio. الdelta anion gap ratio اللي هو calculated, for example in this patient was 24 minus 12. 12 اللي هو standard number that usually we use it in any equation. تمام؟ والcorrected bicarb زي ما تعلمنا في الأول اللي هو actual bicarb اللي هو كان 11 in this patient minus standard bicarb اللي هو 24. So 12 divided by 13 give us a number. So according to this number, we will use this table. So if this number is less than 0.4, it means that either you did the calculation by you did mistake during your calculation and the patient likely have normal anion gap metabolic acidosis. So you should to review yourself. But if the ratio or if the numbers between 0.4 to 0.8, make sure that patient have double metabolic acidosis that include normal anion gap and high anion gap metabolic acidosis. But if the ratio is between 0.8 to 2, the patient have isolated high anion gap metabolic acidosis. But if the ratio is more than 2, that means that the corrected bicarbonate is very low. So there was less presumed of the bicarbonate and there was a retention of the bicarbonate, so the patient will have double metabolic disorders that include high anion gap metabolic acidosis and metabolic alkalosis. So to use a gap ratio or delta ratio, we use it only in case of HAJMA or high anion gap metabolic acidosis to exclude any hidden metabolic or respiratory disturbance that can be associated with this metabolic disease. Fine. Only you run only around 5 slides, then we'll take break. Fine. So this patient who brought by his mother and collapsed and was tuberous in our ER has been diagnosed with normal osmolar high anion gap metabolic acidosis and that associated with respiratory alkalosis. For that, it is important for us to to be aware about differential diagnosis. So we're supposed to be aware of the differential diagnosis of HAJMA or high anion gap metabolic acidosis. And as you knew that that are calculated in traditional mnemonic for causes of HAJMA, which is mad bias that include intoxication like methanol and ethanol, uremia in case of kidney failure, or secondary to diabetic ketoacidosis, or due to lactate, or salicylate poisoning. Or another way to remember the cause of metabolic acidosis by awareing the mechanism of producing these disorders. Right. So patient with high anion gap metabolic acidosis, you should ask yourself a few questions. The first question: does this patient have a ketoacidosis? And the ketoacidosis can be secondary from starvation itself. Ketoacidosis can be secondary from alcohol withdrawal in case of chronic alcoholic patient, or ketoacidosis may be secondary to uncontrolled type 1 acidosis. And to establish this diagnosis, it is necessary to demonstrate presence of ketones within blood or urine, so to detect ketonemia or ketonuria. And the major contributor of ketones in the blood and urine is three things: either beta hydroxybutyrate, a second one acetone, and acetoacetate. الميجر contributor of keto acids اللي هو البيتا hydroxybutyrate, which form around 75% of keto acid in case of diabetic ketoacidosis, and form around 90% of keto acid in case of alcoholic acidosis. And unfortunately, in most of our facility in our kingdom, we are using a nitroperoxide test or dipstick through urine dipstick to detect ketonuria in our urine. And unfortunately, this test sometimes will underestimate or even fail to diagnose ketoacidosis, because a nitroperoxide only can detect a minor contributor of keto acids that consist of acetone and acetoacetate, and usually cannot react with beta hydroxybutyrate. So to avoid this issue, so if you are thinking that patient have a DKA, for example, you should add hydrogen peroxide in the urine, and the hydrogen peroxide it will help to convert beta hydroxybutyrate into acetoacetate, so the urine dipstick will react easily and detect the keto acid. And to diagnose the DKA, we have, as you know, the criteria. However, these criteria, it is not mandatory to diagnose the DKA, because as you know, we have subtypes of DKA called euglycemic DKA, and in addition to that, especially DKA can be compensated, and the compensation can even change an acid-base balance data and can confuse you. And in addition to that, the second table will mention a criteria to diagnose an alcoholic ketoacidosis. Right. The second important questions you're supposed to ask yourself that does this patient have a lactic acidosis? And the lactic acidosis itself, it is one of the common causes of high anion gap metabolic acidosis, and the lactic acid is either generated by an anaerobic mechanism, either resulting from tissue hypoperfusion or acute hypoxemia, that grouped as type A lactic acidosis and can be resulting from shock, different type shock, or acute or severe hypoxemia due to, for example, acute lung disease, or maybe even represent from repetitive seizure or overuse physical activity or overuse musculoskeletal muscles. And these are only categorized and labeled under type A lactic acidosis. And the type B lactic acidosis if there is impairment of use of this lactic acid and may be secondary to many drugs, many hematological malignancy, or certain infection. And to diagnose a lactic acidosis, we have criteria. And most important one, the presence of lactate more than 5 millimole per liter. And why ليس موها type A و type B? Because we have a third type اللي نسميها D-lactic acidosis. D-lactic acidosis, one of the rare cause of high anion gap metabolic acidosis that usually associated with high anion gap metabolic acidosis and usually observed in patients with short bowel syndrome. Short bowel syndrome in patients who did, for example, a procedure or resection that involved small intestine, or patient did certain bariatric surgery. So if there is a resection of huge part of the intestine in patient who received, for example, huge carbohydrate diet, most of those patients with short bowel syndrome will be complicated to have bacterial overgrowth, and this bacteria will metabolize these carbohydrate and transform these carbohydrate into D-lactate, and this D-lactate will be absorbed directly from the small intestine and can cause severe metabolic acidosis. And usually those type of patients will present it to you, for example, in emergency department, or even you can see him in the surgical ward after taking or ingestion of large carbohydrate diet with neurological symptoms, like, for example, confusion or even seizure. And unfortunately, this type of acidosis sometimes missed, because in most of our facility to diagnose lactic acidosis, we are using a standard test to diagnose lactic acidosis by using lactic acid level. So if you are thinking of this diagnosis, you should ask the lab to measure the lactic acid level. And to treat this condition, you should, for example, treat acidosis, so you should infuse bicarbonate. In addition to that, ask patient to avoid a carbohydrate diet and to slow and distribute his diet into small quantity and increase the fiber diet. In addition to that, to treat bacterial overgrowth by antibiotic. Another differential diagnosis of high anion gap metabolic acidosis is salicylate or aspirin poisoning. And this type of drugs can be seen especially among patients who have a psychiatric illness, because salicylate or aspirin is commonly to be found in any and most of our houses. So any patient with metabolic acidosis, especially if this metabolic acidosis that has been associated or combined with respiratory alkalosis, think about salicylate poisoning, because the aspirin or salicylate have ability to stimulate ventilatory drive directly, so those type of patients will have coexistent respiratory alkalosis, like in our previous patient. So the previous patient have high anion gap metabolic acidosis. In addition to that, that associate with respiratory alkalosis and usually presentation. In addition to mental status changes, the patient may be presented with tachypnea, tachycardia, even cardiovascular compromise, including pulmonary edema and GIT hemorrhage. And to diagnose this condition, so if you are seeing a patient with, for example, high NGAP, Hajma associated with respiratory alkalosis, salicylate poisoning need to be ruled out by checking the serum or even a urine level for salicylate. And to treat this condition, in addition to support and secure the cardiorespiratory system, it is important to treat acidosis by using sodium bicarb infusion to improve excretion and removal of salicylate acid, in addition to keto acid and lactic acid that can be associated with salicylate poisoning. And it is important even to ask your colleague from nephrology department to think of hemodialysis, especially if the level is very high, for example, more than 80 milligram per deciliter, or if the major organs are affected. That includes the central nervous system, cardiovascular, or respiratory system. So in this situation, hemodialysis may add a benefit in those type of patients. Right. In the previous scenario, the osmolar gap was normal, but suppose the osmolar gap is 15, so more than 10. So you should ask yourself, did our or my differential diagnosis will keep the same, or I suppose to change this differential diagnosis? Okay. So you suppose to change your differential diagnosis. In this situation, intoxication need to be ruled out. The most common toxin that can associate it with increased osmolarity in case of high anion gap metabolic acidosis is methanol. Methanol intoxication and ethylene glycol intoxication. However, rarely high osmolar gap, high anion gap metabolic acidosis can be noticed in patients with severe lactic acidosis, especially if induced by metformin, and also can be seen in case of diabetic ketoacidosis and the other causes that mentioned in this slide. And already we knew how to calculate osmolarity. So if the osmolarity, make sure that if the osmolarity is more than 10, make sure that toxins need to be ruled out. طيب, one of the common toxins that can increase osmolarity in case of Hajma is ethylene glycol, which is a component of antifreeze and solvent. And the metabolism of these drugs is by alcohol dehydrogenase that generate a ferrous acid, including commonly a glycolic and oxalic and lesser amount of formic acid. And initially manifested by neurological manifestation that similar to ethanol intoxication, including seizure, coma, that can be developed rapidly within the first 12 hours, and within 12 to 14 hours, patient may have, or this toxins may complicated by non-cardiogenic pulmonary edema and acute respiratory distress syndrome. But after 24 hours, patient may have a kidney failure due to acute accumulation of crystal commonly related to calcium oxalate crystal, which have enveloped shaped crystal that precipitate and occlude the tubules of the kidney and leading to crystal-induced nephropathy or obstructive nephropathy. So if you are thinking of ethylene glycol, you can check a patient urine by doing urine microscopy. And if you are seeing this crystal that have a unique shape like rhomboid or envelope shaped, this can aid a clue to your differential diagnosis. طيب, another toxins, الميثانول. الميثانول is same, is metabolized by alcohol dehydrogenase, but the major contributor ولا metabolite of the methanol is formic acid. And unfortunately, formic acid have high toxicity to the retina and can lead to irreversible blindness. In addition to that, the formic acid have increased incidence to cause hemorrhage along the basal ganglia, leading to extrapyramidal syndromes and signs and symptoms, and leading to hemorrhage within the white matter of the brain. So, if patient have high osmolarity with high metabolic acidosis and coming to you complaining of disturbance of his vision or history suggestive clinical features of extrapyramidal disease, think of methanol intoxication. And the treatment for this intoxication is the same. So including supportive measure, maintain airway, secure breathing, correct hypotension, and treat patient in monitor room. In addition to that, you suppose to prevent the formation of these toxic metabolites by using fomepizole, which is the primary therapy, and if it is not available, we can use a competitive therapy اللي هو الإيثانول, and it is important to correct acidosis by using sodium bicarb, and you should ask even your colleague to initiate hemodialysis if indicated to remove this toxins and its metabolite. طيب, we will get if you don't mind, we will get a break because I will pray al-dhuhr. Then by 2 we will continue our lecture, and I believe it will take only 1 hour. تمام؟ الحين إن شاء الله بريك صلاة الظهر والساعة 2 إن شاء الله راح نبدأ. Bismillah ar-Rahman ar-Rahim. Welcome back. We will continue our lecture regarding interpretation of ABG. So just now we finished the high anion gap metabolic acidosis, and now I will concentrate to other types of metabolic acidosis, which is normal anion gap metabolic acidosis. To remind you, in case of high anion gap metabolic acidosis, we have two extra steps. An extra step that include measurement of osmolar gap. In addition to that, measurement of delta ratio or gap ratio. Otherwise, the other steps to analyze any ABG will be the same. But in case of normal anion gap metabolic acidosis, also there is a special step and unique for this disorders, and we'll mention it in coming few slides. So you are seeing a patient who is a 32-year-old woman with progressive quadriparesis. The patient also complaining of joint pain, dry mouth, stiffness, and Raynaud, which is clear in this picture. You did for her an ABG and certain lab test. The pH was 7.23, BCO2 29, bicarbonate 12, sodium 137, potassium 2.1, and chloride 115. Okay, so we will solve this ABG and we'll follow the same steps that we already know to use. So first step, what is the pH? pH 7.2 is less than 7.4. So likely the patient turned in the zone of acidosis. So the patient have acidemia. So the next step to check the BCO2. The patient BCO2 is less than 40. So patient with acidosis and the BCO2 less than 40. So likely the patient have metabolic acidosis. Right. Then it is important to check an anion gap. Anion gap for this patient will be 10. So between 10 and 14. So patient have normal anion gap metabolic acidosis. So it is simple. Then we're supposed to assess the respiratory compensation. Is it adequate or not adequate? So primary, so I will calculate an expected BCO2. So I'll assess a respiratory, I will assess a response of the body by doing respiratory alkalosis. By doing respiratory alkalosis. So I'll calculate the expected BCO2. So I'll use 1.2, then I will multiply it by corrected primary corrected by carbon, because the primary disturbance here is metabolic acidosis, and because the metabolic acidosis will be compensated by respiratory alkalosis, so I will subtract this number from 40, or standard number of BCO2, because the BCO2 is supposed to will drop, because the body will hyperventilate and try to remove the extra carbon dioxide, as we learned previously, plus minus 2. So expected BCO2 is supposed to be within 23.6 or 24 to 28, because we are correcting these number. And the BCO2 here is within this range. So this patient will have double acid-base disturbance, normal anion gap metabolic acidosis associated with, compensated with respiratory alkalosis. So the patient, so the patient have isolated acid-base disturbance that consists only of normal anion gap metabolic acidosis. Right. So the second questions. In case of normal anion gap metabolic acidosis, we suppose to know the causes, because we are physician. We are not statistical scientists. For that, it is important to know the differential diagnosis of metabolic of normal and gap metabolic acidosis. And as you know, it's either related from kidney, and this is called renal tubular acidosis, or maybe originated from outside the kidney or extrarenal, and commonly related to gastrointestinal tract loss of bicarbonate, likely in secondary to diarrhea, or other extrarenal causes, like, for example, loss of secretion from biliary or pancreatic secretion in patient who did surgical procedure, or patient who have chronic inflammatory conditions that complicated by fistula, that created connection between bowel and these organs, like pancreas or pancreas or bile, from bile duct, or patient who did the urethral diversion. So in case of urethral diversion, if patient who has certain congenital types of obstructive uropathy, we are connecting the ureter with the ureter to the bowel. So there will be connection. So the urine will expose to small intestine. So it will stimulate removal of bicarbonate and absorption of ammonia and chloride that can create a normal and in-gap metabolic acidosis. So if you are facing a patient with normal and in-gap metabolic acidosis, you should differentiate that either that acid or extra acid originated from kidney, which called renal tubular acidosis, or originated from from outside the kidney or extrarenal, likely from GIT tract, and commonly related to diarrhea. So to differentiate these two categories or two main causes of normal and gap metabolic acidosis, it can be differentiated first of all by history. If patient, for example, he mentioned to you that he has a diarrhea, so he gave you already the answer. But some patients are ignoring or hiding these symptoms for secondary opinion. For that, we're supposed to confirm the source of this acid by checking the urine, by checking the urine ammonium level. So we're supposed to check urine ammonium اللي هي NH4 exertion in the urine. That will confirm the cause of condition. So in case of extrarenal causes, usually the renal tubules are intact, and the ammonium اللي هو consists of NH4. NH4 اللي هو ammonia اللي هو NH3 in addition to hydrogen. And hydrogen, one of the major contributor of acid. So in case of extrarenal causes, if the cause is not related to the kidney, so the tubules, including proximal tubule or even distal collecting tubule and collecting tubule, so the cells that are responsible to control acid-base balance, are intact. So the secretion and reabsorption, secretion of acid or reabsorption of bicarbonate or alkali are intact. So usually exertion of ammonium will be high, which reflected by high level ammonium exertion, and reverse is true. So in case of RTA, usually the urine ammonium level, or one way to remove these extra acid by kidney, are impaired. So the urine ammonium level will be very, very low. But unfortunately, in most of our hospital and facility, we could not measure the urine ammonium level. For that, indirectly can be assessed by calculating a urine anion gap by using this formula. So we are using a measure anion and cations. So urine anion gap, we are measuring urine solid plus potassium, and we will subtract it from urine chloride. So if the urine anion gap is positive, it means or reflect inappropriate or والinappropriate ammonium exertion. But if it is negative, it represents huge ammonium exertion and likely related to extrarenal causes like, for example, diarrhea. طيب. Another way to assess or differentiate renal or RTA from extrarenal causes of NEJMA, of normal and metabolic acidosis, by assess urine osmolar gap. So we are using the same equation that can be used to calculate plasma osmolarity, and we're supposed to calculate the difference between measured that are supplied by our lab and subtracted from calculated that you will calculate it. And if the level is less than 30, it means likely secondary to RTA. But if the urine osmolar gap more than 80, likely represent extrarenal causes. Right. So for the previous patient, the physician asked for patient urine electrolyte to calculate the urine anion gap, and the urine anion gap was around 20, which is positive, so compatible with diagnosis of renal tubular acidosis. طيب. Here we learned that if you are facing an acid-based, if you are facing normal anion gap metabolic acidosis, you should add an extra step اللي هو measurement of urine anion gap or measurement of urine osmolar gap to differentiate renal tubular acidosis from extrarenal causes of NEJMA or renal or of NEJMA like اللي هي normal anion gap metabolic acidosis. طيب. The third step, you should ask yourself which type of RTA this patient have, because it is important to differentiate each type from another, because each type have a certain and unique treatment. For example, in case of proximal RTA, usually those patients can gain benefit from diuretic. However, in case of distal type 1 RTA, only correction of acidosis and potassium will be adequate. Right. So as you may knew, we have 3 types of RTA or renal tubular acidosis. And the renal tubular acidosis usually resulting from abnormal hydrogen transport system. And the first one called hypokalemic distal RTA or type 1 RTA. Type 1 RTA, the effect usually resulted from distal proton secretion, because there is impairment with type A intercalated cells that found in distal and common duct. So the tubules have a difficulty to release these protons in circulation, so have a difficulty to acidify the urine. So in case of type 1 RTA, it will be characterized by 5 things. First of all, normal anion gap metabolic acidosis. Those type of patient will have even hypokalemia, which likely to be severe. In addition to that, if you are checking the urine anion gap, usually it becomes positive. And if you check LPH, the patient usually have failure to acidify the urine. So the urine pH will be more than 5.5. And the final characteristic features of type 1 RTA is a huge or high concentration of bicarbonate, because bicarbonate is 85% is reabsorbed from proximal tubule, and the proximal tubule, which work to absorb all or substance and element that are filtered by afferent arteriole. In case of type 1 RTA, this type of tubule are working and have intact function. For that, most of the bicarbonate are reabsorbed. So you will find small concentration of bicarbonate in there. Right. Another characteristic finding, usually patients with type 1 RTA, usually those type of patients will have reversible nephrogenic diabetes insipidus. So the the plasma sodium will be high and patient will complain of frequent polyuria. And nephrogenic diabetes insipidus, it seems to be secondary to severe hypokalemia. In addition to that, those type of patients who have type 1 RTA are more prone to have recurrent kidney stones or nephrolithiasis and even calcification of the renal cortex. And the causes of those complications is due to inadequate it's due to inadequate acidification therein. The second cause is due to inadequate citrate filtration, and the third one due to severe acidosis. And the severe acidosis lead to bone resorption of calcium, and most of this extra calcium will be filtered through tubules and removed by kidney and can accumulate in alkaline phase to form a kidney stones. So if you are facing a patient with normal NGAB metabolic acidosis and have a history of recurrent kidney stones, make sure that this type of patient likely have a type 1 RTA. And I want from you to remember these characteristic findings. Common causes of RTA commonly secondary to autoimmune disease. Commonly secondary to autoimmune disease, like in the previous scenario. So if patient with RTA and came and have non-autoimmune disease, for example, Sjogren or even sarcoidosis, think about distal RTA. Another common types of RTA or type 2 RTA, the proximal RTA. And as you knew that the proximal tubule is responsible for reabsorb most of the element and substance and fluid that filtered by afferent arteriole. So the primary defect is either isolated defect within bicarbonate reabsorption or generalized dysfunction of proximal tubule that called Fanconi syndrome. And Fanconi syndrome, it's characterized by presence of uricosauria, so high uric acid within urine, aminoaciduria, so huge amino acid seen in the urine, proteinuria, phosphate urea, so huge phosphate in the urine. So if you are and glycosuria, that means presence of glucose in the urine in patient who is euglycemic, so he has normal plasma glucose, or controlled or patient who have controlled diabetes, so plasma glucose not more than 40, but accidentally you find glycosuria within urine. So make sure that likely this type of patient have a Fanconi syndrome in which there was a generalized dysfunction of the proximal tubule. This type of RTA characterized by presence of normal anion gap metabolic acidosis, positive urine anion gap, have intact ability to acidify the urine, so the urine pH is less than 5.5, and there was a huge concentration of bicarbonate within urine. So the bicarbonate concentration in the urine, if you are checking it, fraction exertion bicarbonate will be more than 15%. So that reflect poor reabsorption bicarbonate within this part of the tubule. Right. So we knew that we have some clues to differentiate type 1 from type 2. Type 1 have impaired ability to acidify the urine, but type 2 have intact ability to acidify the urine. Type 1 have low bicarbonate concentration in the urine, but type 2 have huge concentration of bicarbonate in the urine. Type 1 can associate it with nephrolithiasis or kidney stones and osteomalacia, but type 2 cannot. Type 2 can associate it with osteomalacia. Why osteomalacia? Because proximal tubule also responsible for vitamin D dihydroxylation. So, and you know the function, vitamin D, one of those functions is calcification and mineralization of the bone. So those type of patients are prone to develop osteomalacia. In addition to that, patients with type 2 RTA have, as we mentioned, have hypophosphatemia. So the low, because increased phosphate that removed by kidney. So the plasma phosphate will be very low. And phosphate, as you know, it is important in bone calcification and mineralization. So it is important to differentiate those two types of acidosis. In addition to that, I will add 2 points. In case of distal RTA or type 1 RTA, usually acidosis is very severe. And usually bicarbonate is less than or equal to 10. But in case of proximal RTA, usual bicarbonate is running between 16 to 18. تمام. طيب. تمام. The common causes of proximal RTA is likely related to malignancy. For example, myeloma, or maybe related to certain drugs like tetracycline or gentamicin. And the common cause in pediatric population is cystinosis. So if you are facing this in any MCQs, the most common cause of proximal RTA in pediatric is cystinosis, but in adulthood is Wilson disease. In adulthood is Wilson disease. Right. Right. A third type of RTA is type 4 RTA or distal RTA type 4, characterized by normal anion gap metabolic acidosis, but hyperkalemia. So the previous 2 types was associated with hypokalemia, but type 4 associates hyperkalemia. And the urine anion gap will be positive, so compatible with diagnosis of normal anion gap metabolic acidosis. But a urine pH can be alkaline or acidic according to the cause. So if it is related to mineralocorticoid deficiency, usually urine pH will be acidic. But if patient have mineralocorticoid receptor resistance or destruction of the mineralocorticoid receptors, usually urine pH will be alkaline. And these are the common causes of type 4 RTA, and still the most common cause of type 4 RTA is diabetes, and the common drug-induced type 4 RTA is non-steroidal use of non-steroidal anti-inflammatory drugs. وهنا زي ما as we saw here, also SLE can associate it with type 4 RTA. In addition to that, also can associate it with type 1 RTA, the distal RTA. Right. So in the previous scenario, the patient have a normal anion gap metabolic acidosis, and when we check his urine anion gap, it was positive, and the urine pH was alkaline and potassium was very low. So the patient met a diagnosis of hypokalemic distal RTA. And because of the presentation, we use these steps in addition to history and physical examination. While patient was complaining of dry mouth and dry eyes and multiple joint pain. So those all together are compatible with diagnosis of Sjogren syndrome, which is one of the autoimmune disorders that affect many exocrine glands like salivary glands. Right. Right. Now I will move to metabolic alkalosis. So we'll start with the scenario. You are seeing a patient who is a 42-year-old man admitted to the hospital with severe upper GI bleeding and setting of liver cirrhosis. For that, he required around 6 units of backed red blood cells and 4 units of fresh frozen plasma to maintain hemodynamic stability. On the second day, the intensive care unit physician request his investigation are shown in this slide. So sodium 136, potassium 4.5, chloride 85, bicarbonate 38, pH 7.52, BCO2 48, and urine chloride was very low, less than 5 milliequivalent per liter. Right. So we will solve this ABG. So we will follow the same steps. The first step, what is the pH? For this patient, the pH 7.52. So more than 7.4. So this patient have alkalosis. So the second step, I will check the BCO2. What about the patient BCO2? BCO2 is 48. So it is more than 40. So the patient likely have metabolic alkalosis. Right. Then, as I informed you, for any patient or any ABG interpretation, we're supposed to measure an anion gap because high anion gap metabolic acidosis can associated with any acid-base disorders. Right. An anion gap in this patient was normal, 13, between 10 and 14. So this patient did not have coexistence HAJMA or high anion gap metabolic acidosis. Then I will assess the compensation. And in this patient, he has a metabolic acidosis and likely it will be compensated by respiratory acidosis. So I will check the expected BCO2. It will be 0.6. Then I will multiply it by corrected bicarb plus 40 plus minus 2. Finally, expected BCO2 it's between 47 to 51. So I will compare the BCO2 which is 48. So BCO2 it is within this range. So the actual BCO2 within the range of expected BCO2. So this patient only have isolated metabolic alkalosis. طيب. Unfortunately, the metabolic acidosis it's more difficult than other acid-base balance disorders. And the pathogenesis of metabolic alkalosis require both generation and maintenance of this disorder. Generation may result from net gain of bicarbonate or net loss of non-volatile acid, like hydrogen chloride in case of vomiting from extracellular fluid. Under normal circumstances, the kidney has or have impressive capacity to remove the extra bicarbonate. However, to maintain the maintenance phase of metabolic alkalosis, usually the kidney fail to compensate or to remove this extra bicarbonate. And usually the kidney fail because of 4 reasons. Either due to volume contraction. So if there is a volume contraction, so the proximal tubule will be overactivated. So the absorption of bicarbonate will be very high. Or maybe due to reduction of the glomerular filtration rate. Or if patients have severe or depletion of potassium and chloride, and potassium may be secondary to overactivation of aldosterone. or renin-angiotensin system. For that, to define the cause, we should know these data by, for example, extracellular fluid by examining the patient, and blood pressure and serum potassium by checking serum potassium, because under each one of them there are many differential diagnoses. So in case of patient who are volume depleted or hypotensive, these are the common causes of metabolic acidosis. But if patient who is hypertensive or even not responding to bolus of normal saline, usually these are the common causes. طيب. After we getting these previous information, we're supposed to ask ourselves these questions, the first questions. Because if we answer this question, sometimes we can, if we answer these questions, sometimes we can diagnose a condition without doing multi-investigation. So the first questions, does the patient who having metabolic acidosis received exogenous alkali, like for example, sodium bicarbonate or lactate? Lactate commonly used for total parenteral nutrition, or used in patient who receiving plasmapheresis or even hemodialysis. Or does this patient have received acetate? Also used, can be used in TBN. So if patient use this exogenous alkali, we can correct and stop and discontinue using these alkali, and we can correct the condition. Or if patient received massive blood transfusion, or even plasma transfusion, because those type of transfusion, usually the blood or the plasma are mixed with some anticoagulant called citrate, and citrate in each 1 unit of blood, it consists of around 100 to 180 milligram of citrate, and citrate will metabolize by liver into bicarbonate, so it will increase a level of alkali that are circulated in our blood. Or if patient is using plasmapheresis, because in many conditions we are using a citrate as anticoagulant to prevent clotting within the filter that used to dialyze or remove separate plasma from other content of blood. Or if patient use antacid that consists of huge amount of bicarbonate. So you should fulfill these all questions. And the second question, we're supposed to ask ourselves, does the patient have hypercalcemia? Because hypercalcemia itself can maintain a phase of metabolic alkalosis by inducing natriuresis, and can cause hypokalemia and hypomagnesemia, and can increase bicarbonate resorption. And also another question we should ask ourselves, does the patient have refeeding syndrome, especially if patient who is poor and who is not taking not taking food for many days, for example in Africa, if he ingests many drugs, it can induce metabolic alkalosis by well understood mechanism, likely secondary to hypophosphatemia and hypomagnesemia. Right. Then we're supposed to check the blood pressure and check urine chloride. And urine chloride, it is one of the important electrolytes that can reflect the volume status of the patient. So if the urine chloride is very low, likely patient have intravascular depletion, and vice versa. And these are the common causes. So I will try to run to save time, because I have an issue after 20 minutes. Tamam. So this patient who presented to you with hematemesis, and he is found to have severe metabolic acidosis, if you are reviewing only his history, likely this patient have two items that can be responsible for metabolic acidosis. So he received 6 units of blood and 2 units of plasma, and all of those blood products have huge amount of citrate. So he received huge alkali therapy, and because the patient have a history of severe hematemesis, likely the patient was hypotensive. So the glomerular filtration rate will be low, and the patient will have intravascular depletion. So the resorption of the bicarbonate will be high, and these two mechanisms are likely responsible for this condition. So to treat this condition, first of all, rehydration of the patient. Then we can use acetazolamide. Acetazolamide, it is one of the carbonic anhydrase inhibitor, or one of the diuretic that inhibit the action of proximal tubule to reabsorb bicarbonate. So likely we are creating type 2 RTA to treat metabolic acidosis in this situation. طيب. We'll move to the respiratory illness. Either we are facing patients with respiratory, it's divided into respiratory acidosis or alkalosis. So we'll start with this scenario. You are seeing a patient who is a 64-year-old gentleman with history of COPD, present with worsening shortness of breath, increased sputum production. The patient ABG is mentioned as you see, and other values are within normal range. So I get from this scenario that patient have a chronic lung disease, and likely patient now presented with exacerbation of the symptoms, and likely this represent either respiratory illness in terms of respiratory acidosis that may be secondary to COPD, or may this patient have a metabolic acidosis. And as you know, the metabolic acidosis will compensated by respiratory alkalosis. So those type of patient will have hyperventilation, so the respiratory rate will be very high. So we will solve this ABG. So the first step, what is the pH? The pH is less than 7.4. So a patient pH is 7.2, so less than 7.4. So likely the patient have acidosis. A second step, what is the BCO2? BCO2 for this patient is 70, so it is more than 40. So likely it's simple. So the patient likely have a respiratory acidosis. So a third step, in any patient, either metabolic or respiratory disorders, we should supposed to calculate the plasma anion gap, because to remind you, a high anion gap metabolic acidosis can associated with any acid-base disorders. The patient anion gap is as the following. So 10, an anion gap is normal. So this patient have until now isolated respiratory acidosis. Then for the step, if this respiratory is acute or chronic, it is chronic. So this is a mistake. So this slide I mentioned it is acute. So unfortunately, so it is chronic because this patient known to have chronic lung disease. So this patient known to have chronic lung disease because the patient diagnosed previously with COPD. But if patient does not known to have chronic lung disease, I will go to the onset of symptoms. If symptoms is beyond 8 hours, this is chronic. If the onset of symptoms is less than or equal to 8 hours, this is acute. So the fourth or fifth step, I will assess a metabolic compensation. Either is it adequate or not adequate, because the respiratory acidosis is supposed to be compensated by metabolic alkalosis. For that, I will calculate the expected bicarb. So 0.3 multiplied by the primary disturbance, اللي هو corrected BCO2, And in case of metabolic alkalosis, usually the bicarb will increase. So plus 24 plus minus 2. So range, expected BCO2 is supposed to be between 29 to 35. And compare an expected bicarbonate to the actual bicarbonate. So it is running within the range. So this patient likely have isolated respiratory acidosis that has been compensated by metabolic alkalosis. And these are the causes, the common causes of respiratory acidosis. And these are the causes of acute and chronic causes of respiratory acidosis. طيب. آخر scenario. You are seeing a lady, which is a 23-year-old lady, medical student on emergency department. She was complaining of dizziness, and carbopetal spasm that developed acutely in the last 3 hours since she knew her result in OSCE. After surgical exam. طيب. From a scenario. So she is a young and she is complaining of dyspnea. So while she is complaining of dyspnea, I will think either the patient have a respiratory illness or maybe metabolic acidosis. Respiratory illness, which I meant by respiratory illness, either acidosis or alkalosis, because all of them can be presented with. So either this patient have, so this patient was complaining of dyspnea. So this patient either he has respiratory illness, either respiratory acidosis or alkalosis, or the patient have metabolic acidosis due to hyperventilation, and all of them can be presented with dyspnea. But to differentiate respiratory alkalosis from respiratory acidosis by counting a respiratory rate. A respiratory rate in case of acidosis will be high, but in case of respiratory alkalosis usually will be low, and for that patient will complain of dyspnea. Type. In addition to that, the patient have a carbopetal spasm. Carbopetal spasm, this is a pathognomic of hypocalcemia. Pathognomic for hypocalcemia. So if you are trying to connect an information all together, so hypocalcemia, one of the causes of hypocalcemia is alkalosis. What? Okay, so one of the causes of hypocalcemia is alkalosis, because alkalosis can change an ionized form of calcium and change a binding with albumin. So it will increase the binding albumin and globulin to calcium. So the ionized form of calcium or free calcium will be very low. And we are supposed to confirm this thing in interpretation of the ABG. So when I saw this scenario, I will think the patient likely have hypocalcemia may be related to alkalosis. Alkalosis, while patients complaining of dyspnea, so likely alkalosis is respiratory. But we will confirm this by solving this scenario. Right. So we'll follow the same step. First of all, what is the pH? The pH for this patient. Okay. The pH for this patient is, okay, so I think there is a mistake. طيب, the pH for this patient is less than 7. Sorry, the pH for this patient is more than 7.4. So the patient have alkalosis. أنا بس كتبت العلامة غلط. So the pH is more than 7.4. So the patient is in alkalosis zone. The second step, I was supposed to check the BCO2. The BCO2 is less than 40. So likely this represents a respiratory alkalosis. third step, as now all of us are know this step, this importance of the step, we're supposed to check an anion gap. Anion gap is normal, so we are excluding coexistence normal anion gap metabolic acidosis. Then I supposed to check if patient have if the metabolic compensation is corrected or not corrected. So for that, I supposed to check the expected bicarbonate. The expected bicarbonate, because in this scenario, the onset of symptoms is acute. So we'll use 0.2 instead of 0.4. And the expected bicarbonate was supposed to be between 20 and 22. So we'll compare the expected bicarbonate to the actual bicarbonate. So it is within this range. So this patient likely have isolated respiratory alkalosis, but have a likely isolated respiratory alkalosis, but I suppose not to mention compensation. I said not compensated by metabolic acidosis. Why? ليه ما قلت إنه associated with metabolic acidosis مع إنه ما جات في نفس الرينج. Because the bicarb, it is not dropping to this range. So higher than expected, but I cannot accurately assess the compensation because قلنا في الأول قلنا الكدني require 8 hours to try to start the compensation and at least 24 hours to approach a complete compensation. But the onset of symptoms for this patient scenario is less than 8 hours. So I cannot comment on patient compensation. So this patient have only isolated respiratory alkalosis. And these are the causes of common respiratory alkalosis. For this patient, the primary therapy is reassurance and rebreathing into closed bag or closed system to allow him to exhale carbon dioxide that will be adequate to solve the acid-base disturbance in this patient. And thank you very much, and forgive me for the many interruptions that I did. And unfortunately, I'm not familiar even with this online course, because I believe an interaction is better than present a case to the computer. And I hope good luck for all of you. And I will thank again all coordinator who did and organize this program, especially in this difficult situation. And I knew most of them now working hard and prepare themselves for assembly, and I hope a luck, and I hope all of you are picking right choice, and I hope all of you are accepted in the specialty that he is dreaming for. Thank you. Assalamu alaikum wa rahmatullah.